same curriculum targeting ST4s as well as ST1. If I have time, I will take maybe 9 hours to teach ST1, the same thing which I'm teaching in 3 hours. But even then, I believe the ST1s might gain something. After the exam, we will come back to a more easier pace for them. The A to Z course requires about 100 hours of teaching, and MSK is the most difficult part of, unchallenged, it is the most difficult part, which we are finishing today. The problem with MSK is that most of the things which are on plain films, which are exam cases, and in your day-to-day life, you are not able to see these pathologies. So that's the limitation. So I always give a lot of emphasis on MSK. So these are the type of hours which we will have to do the teaching in the next maybe 12 weeks or so to be able to finish the curriculum. So I was following a textbook of radiology, which is David Sutton, and today I have to cover chapter 7 and 8, lympho, reticular and homeostatic systems, metabolic and endocrine. These are the systems which I will cover today. Chapter 9 and 10, which are trauma, are a different course, that is rapid reporting, and we'll teach you in a separate course, not by myself. Somebody else from the faculty will teach you. So the schedule for the coming meetings are that the next meeting is on GIT. We will start GIT on this Thursday, 1800 hours to 2100 hours, which is my regular teaching day on Thursday. I'm planning a 2 to 3 hour session on the weekend, maybe a Saturday or a Sunday. I'll announce it on Thursday when I'm doing it. We are also targeting an interventional radiology course, which we call interventional radiology for FRCR, in the coming week. And hopefully I'll be able to announce this by the end of the week. So after MSK, I am going to take over GIT, and in tandem, we will do other courses also. Many of you have approached me, and many of you want to practice being a Viva candidate. You have seen our method. We anonymize the Viva candidates so that they are not intimidated, and only I know who they are. So the point is that I've got limitations because I definitely have to give more practice to my own registrars. Having said that, there will always be places for others to join in. For example, today I've got spaces, but so what I have decided is that if anybody of you want to be a Viva candidate in future courses, I cannot promise anything, but on day-to-day basis, I will text you. And if you are available, I'll give you a pseudo name or a number, and you can join the Viva candidate as a Viva candidate. So anybody interested, please email at secretary@drkhansteaching.com, and your subject should be Viva candidate, and give your mobile, and I will then be in communication with yourself directly. Okay, so let's start. Now, candidate 1, can you raise your hand, please? Candidate 1, there is a technical issue at my end. Please do it again because I could not see you. I could see the sign, but I could not find you. Yeah, you are there.
Yeah. Hello.
Can you hear me? Can you hear me?
Yes.
Okay. Before you begin, today, the subject is in both of these chapters, there are many pathologies which most of you will not find a case in your life. You will not see them. Many of you, particularly those of you who are working in UK. So the point is that I will show you many, many, many cases. It's going to be picture after picture after picture. An unusual finding of the same thing which comes in the exam. For example, I might show you 20 different cases of hyperparathyroidism, which is a favorite for exam. So it's going to be an easy session, but concentrate. Your mind should concentrate to develop the picture of particularly unusual findings of something which is common. Okay, candidate one, over to you.
So I'm presented with a frontal radiograph of the left hand of an 11-year-old female patient. The striking abnormality is of medullary expansion of the tubular bones of the hand, which seems to be affecting all of the bones equally without any focal differences. There's thinning of the cortices and reduced trabecular pattern, and the metacarpals in particular have a rectangular appearance with a loss of their usual biconcave shape. There's no obvious cortical destruction or soft tissue component, and there aren't aggressive features. Overall, I would suggest that these appearances represent medullary expansion secondary to, in this age group, an anemia, most likely thalassemia.
Okay, well done. Regarding trabecular pattern, what did you say about trabecular pattern? You felt that this is what? Can you repeat that?
Well, there's sort of reduced numbers of trabeculations and they're thin.
Yeah, so coarse is the way to describe it.
Okay.
It's not fine. It's very coarse, right? Otherwise, your description was absolutely perfect. Now, if this rectangular shape, or some people say squaring of the normal shape of the metatarsals. So this is thalassemia. Now, in thalassemia, what happens is that in the medullary cavities there is a lot of activity going on. There is expansion of the medullary cavities, and this will give you various kinds of pictures. All of them are Aunt Minnie cases. If you have seen it once in your life, you are not going to miss it. And if you have not seen it, then you are going to struggle. So this case, the same finding, if you see here, the exposure factors are not very good. This is from StatDX. But even here, you can see the same finding. Candidate one, just name, describe this. This is thalassemia, we know that. Describe the findings for us.
This is a lateral skull radiograph. There's widening of the diploic space with a hair on end spiculated appearance.
What else is a find? Okay, that's spot on. Anything else? Look at the facial bones. How will you describe it? Any finding there?
I can't see the paranasal sinuses very well.
Excellent. And what does that mean?
So potentially they're under pneumatized, potentially due to medullary expansion as well.
Yeah, so that is a finding. And please remember that these kinds of findings will carry marks in, if you pick it up, you might get half a mark more. So try to pick up the findings, anything more. So this tells you what happens, that there is expansion of the, the maxillary bone, and which simply encroaches the sinus, and the sinus is not visualized. So another stigmata of thalassemia. Okay, over to you, please.
So this is a frontal chest radiograph of a 21-year-old female patient. The lungs appear clear. There's no pleural effusion, pneumothorax, or consolidation. So I'm going to review areas.
Can you describe this thing for me? What is this?
There appears to be, there appears to be increased soft tissue density overlying the right inferior mediastinum. The right heart border is still well seen through this, and therefore I do not think it lies in the adjacent middle lobe. The hemidiaphragmatic contour is also preserved. However, I can't see the right paraspinal line, and I think that is distorted by the mass. So I think this is probably a posterior mediastinal mass. Okay, and I've been supplied with a lateral radiograph, which also confirms the posterior mediastinal location. Otherwise, the lesion's quite large and of just of homogeneous soft tissue density.
Excellent. So what is the differential of a posterior mediastinal mass?
So there are a few things in the differential. So tumors, including nerve origin tumors like neurofibromas and nerve sheath tumors. You can have lymphadenopathy there. And then extramedullary hematopoiesis is one of them.
Okay, excellent. Now, this actually, it is not projected very well here. So I'm going to show you another film, which is a classical 2B film. But in this one, this is from StatDX again. In this one, paravertebral mass is not seen. But both of the films combined together give you a classical 2B film. Basically, on the previous one, you see a paravertebral mass. The YY is going to be around this. Where is it? You know, things like hilum overlay sign and all those things, you should have a concept about that. And the examiner is going to ask you, where is it? Which mediastinum? You say posterior mediastinum. What will you do next? In the real world, we usually do cross-sectional imaging. And your answer will be, I will do a cross-sectional imaging, maybe a CT. Now, the point is that will they show you a lateral chest X-ray? They can, and it is in in this era. I know that most of you you don't see lateral chest X-rays, but it is entirely their own mandate. Whatever they want to show you, they will show you where it is. Just to highlight that one of my students a few years ago, he got a lateral chest X-ray as the first case. So instead of a PA film, the examiner started with a lateral X-ray. And on the lateral X-ray, the student did not get any pathology. So the Viva was more of about, what is this, where is the right hemidiaphragm, where is the left hemidiaphragm, normal anatomy of a lateral X-ray. And then he was shown a PA film after the lateral. So the point is that lateral X-ray, I know it's a weak point for the present generation, but you have to know. Less chances, but you have to know. So look at this case where you can see these expansion of the ribs and how they are expanded. And this gives you that, this plus a paravertebral mass means thalassemia. So it becomes what we call a story film together. So posterior mediastinal mass is in adult, and extramedullary hematopoiesis even in adults, and of course extramedullary hematopoiesis in childhood, both of them. Favorite exam cases. How do you describe this appearance?
So there's medullary expansion of the distal femur causing an Erlenmeyer flask-shaped deformity.
Give me 3 causes of this bookish differential.
So anemia such as thalassemia, which you've given, lysosomal storage disorders like Gaucher's disease, and PIC, Niemann-Pick would be another one.
So thalassemia.
And fibrous dysplasia can look like this as well.
Fibrous dysplasia. Fibrous?
I think so.
Okay, so here you are. So Erlenmeyer flask deformity. Osteopetrosis is an exam case. Thalassemia is an exam case. rare, but you should know. This is a more important exam case. This is very important. I'll show you in the next session. Yes, please. Head of the femora, normal, abnormal?
Abnormal.
Both or?
I think the abnormality is more on the left.
Mm-hmm.
There's sclerosis and subchondral irregularity of the left femoral head.
And on the right?
Yeah, less so.
Okay, so you think both are abnormal, but left is more. So what is your diagnosis?
So the findings are in keeping with avascular necrosis, potentially secondary to sickle cell anemia, if there are other features.
Okay, so of course in the exam, because you know you are in this chapter, the viva will be slightly different. Once you pick up this and your differential is bilateral avascular necrosis, then will come the differential diagnosis. What can be the causes? And you know, causes, of course, sickle cell is one of the causes, but Cushing's, etc. You know, there are multiple causes of bilateral avascular necrosis. So the viva will be in that style, should I say. Okay, just look at the thoracic spine. What is your finding?
There is central end plate depression at multi-levels, potentially indicating vertebral end plate infarction, so H-shaped vertebra.
What will you do next?
I'd look at a lateral. Well, I'll do a lateral spine film.
Here you are.
That confirms the findings. So there's sclerosis and depression at the central part of the superior and inferior end plates of multiple vertebrae.
Conclusion?
So I think this is also secondary to avascular necrosis.
So the diagnosis?
So most likely sickle cell anemia.
Right. So what happens is in sickle cell anemia, the concept is that on this end plate, anteriorly and posteriorly, there are multiple small arteries, but here there are more end arteries, you know, small arterioles, which get plugged up because of the sickling. And this portion actually collapses and this one stays normal. On a CT scan, but the but is, do not think that this pattern is visible in each and every case. Sometimes it can be, you know, completely like this also. But having said that, H-shaped vertebrae is quite, you know, important for the exam. They will show you on a chest X-ray, and you have to pick it up. And in the exam, you might like to ask the examiner to give you, you know, you can change the densities and see the spine, etc. So this is the differential of multiple collapsed vertebrae. And here, sickle cell anemia is one of the list. Now, sickle cell disease, two things you have to remember with sickle cell. First of all, you know, it will cause bone infarctions. Please remember the basics that the word when their epiphysis is involved, we usually call it avascular necrosis, but otherwise we call it you know, when it is metaphysis or diaphysis, we use the word infarction. It is actually the same thing. So it all depends on the case. There can be multiple sclerotic foci. There can be generalized increased bone density. So slightly different differential diagnosis. You know, in one of them, most of the skeleton is high density. In second one of them, there are multiple foci of sclerosis. Second thing which you have to remember for sickle cell is that these patients are prone to develop osteomyelitis. You know, Salmonella osteomyelitis is very common in them. So exam cases can come where a patient has got stigmata of sickle cell and has presented with osteomyelitis. So initially, you will pick up the osteomyelitis, and the examiner will grill you, what is the cause of this? You know, and you will be confused what's happening. Actually, you have to look at the rest of the portion of the bone, and you might see some sign of sickle cell. So that will become what we call a story film. So these type of things you have to remember for the exam. Now look here, most of the bone is sclerotic. So here will be the differential diagnosis of uh, generalized increased bone density. And here what is happening that there are infections, and infections in the small bones of the hands and feet are quite common. Look at this case. Periosteal reaction, something is there, increased bone density, something is there. So please remember that osteomyelitis film can come in the exam. Over to you. Classical exam case, absolutely classical.
So this is an abdominal radiograph of an adult patient. There's a right total hip replacement in situ. Other abnormalities that I notice is calcified small spleen in the left upper quadrant, and again some abnormality of the vertebral end plate. The overall appearances are of sickle cell anemia, with the hip replacement being explained by severe AVN of the right femoral head.
Okay, excellent. So this is a classical exam case which tells you a story. The story is that the patient, so this is a calcified spleen because of autosplenectomy, and there are a few vertebrae which are possibly head-shaped. And this tells you that the patient must have had a avascular necrosis in the past, and because of that, this is replacement. So it's a classical story film, classical for the exam. So another one, and this is another classical case from StatDX. If you can see here that there is, place yourself in the exam world and see what will happen in the exam. You will go on and on this film. Lung is clear, this is clear, that is clear. And then you will pick this up. Once you pick it up, then you look here, something is there. And then you look carefully, and maybe a few of these vertebrae are slightly head-shaped. And then a bit of stretch of imagination. But having said that, 2 + 2 makes 4. So the unifying, this bubble should not be sitting here. Usually there is a spleen which sits here. So this patient must have had a splenectomy. So you can infer this might be an autosplenectomy, but you don't see any calcification. But sometimes the calcification is so small that you might not see it on a plain film. Just give me the finding, please.
So again, there's a calcified small spleen in the left quadrant.
Yeah, that's fine. So this is the type of, this is autosplenectomy, and just a calcified spleen which has completely replaced where the spleen should have been. So that's fine. Okay, over to you, please.
So I'm presented with frontal radiographs of the knees of a pediatric patient. I presume these are left and right, so both knees. Yeah. There is an abnormality of the metaphyses bilaterally, which are widened with a sclerotic edge adjacent to the physis, and then in the metadiaphyseal region, there is lucency with patchy sclerosis and thinning of the cortex. The tibial epiphyses appear to have a slight degree of sclerosis around their edges as well. And there's some spurring at the lateral aspects of the tibial metaphyses bilaterally. Overall, I think the appearances are most consistent with scurvy.
Why have you, why scurvy? Convince me.
Well, I think I think the epiphyses are generally lucent but with a sclerotic edge. I think there's dense provisional calcification at the metaphysis. Then there is, after that, there's a lucent area of impaired ossification. And I think these changes are consistent with that diagnosis.
Okay, I don't want to come out of this PowerPoint because it will take me some time, because scurvy I'm going to teach you in the next chapter. But in scurvy, what happens is that there is a Wimberger sign. Basically, what happens is that the epiphysis is hypodense, and then there is a pencil-thin cortex. This is not the appearance of that. This appearance is slightly different. Here, what is happening, that whole of this metaphysis is abnormal. This metaphysis is abnormal, this is abnormal, this is abnormal. Actually, the metaphysis is, it gives you an aggressive type of an appearance. It's not something very, benign. So this is the differential diagnosis of what we call metaphyseal lesions. And scurvy we will learn in the next chapter. Now, this is in your book. There is a differential diagnosis, solitary radiolucent metaphyseal band. One can argue that this is not a solitary band, it's more, but the take-home point is that it is metaphyseal abnormality. So you can actually consider the same differential. Now, in this differential, look at number 5 here, leukemia, lymphoma, or metastatic neuroblastoma. Aggressive lesions, these 3 should be in your list. So rest of the stuff, syphilis we had done earlier, but rickets and scurvy we will cover in the next chapter. So just please wait for that. So this is a more classical, that solitary lucent metaphyseal band. And this is again a case of leukemia. The previous one was a case of leukemia. Leukemia goes with mets from neuroblastoma in this age group. These are the most common. If you go back, leukemia, metastatic neuroblastoma. These 2, they go together, and in differential diagnosis, you have to call them in the same breath. So just to make a point, that this patient, if you look carefully, this is the cortex, there is a periosteal reaction here. And this was a case of leukemia, but this is not at all pathognomic. So nobody is going to show you this in the exam. They will show you something like moth-eaten appearance or metaphyseal lesion. This is another case in which you can see diaphyseal abnormality with a lot of edema surrounding it. Okay, this is a very, very, very good case. So classical 2B, if all of you can concentrate on this. Yes, please.
So this is a frontal radiograph including the chest and abdomen of a child patient. Just first, there's no obvious acute lung lesion, no clear pneumoperitoneum. Looking at the bones, I don't know if the axial skeleton looks a bit diffusely sclerotic, but I'm not sure if that's projection.
Don't worry. That's just projectional, so don't worry about that.
There's a bit of radiolucency at the metaphyses of the humeri bilaterally, both proximal and distal. Just quite ill-defined.
So you have picked up something here and maybe something here. Okay.
Yeah.
This one is a definite finding. Agreed?
Yeah, I think there's reduced bone density in the sort of proximal humerus.
So proximal means metaphysis, right?
Yeah.
Now with that, anything in the abdomen?
There's increased soft tissue in the upper abdomen. It looks like either hepatomegaly or hepatosplenomegaly.
Okay, so either hepatomegaly or hepatosplenomegaly. Okay. Now, Same case, I'm showing you the femora, just to make a point. And what are the findings in the femora?
So again, there are definite eccentric metaphyseal lucencies. For example, most prominently of the distal left femur, where there's some irregularity of the cortex and then lucency within the medullary bone.
Okay, now, so that's very good. So what we have picked up that there are metaphyseal lesions. You remember that differential. So we are continuing with that differential. And now again, this, there are metaphyseal abnormalities and they look aggressive. With that, you have found something in the abdomen. Question, you were worried about some soft tissue here, right? So what is going to be your next investigation? What are you going to advise? Viva question.
So I'd want to image the abdominal organs. An ultrasound would be a good start.
Excellent. So that's the correct answer. So please remember in your Viva, whenever there is a baby, go for ultrasound, and radiation is extremely important. So ultrasound is the first call of duty. And what do you think is happening? Just concentrate on this picture, this bottom one.
Okay, there looks to be, I think that's the right kidney that we're seeing. Mm-hmm. And it's expanded, it's hydronephrotic, there's a loss of corticomedullary differentiation.
Let me help you. This is the liver, this is the kidney, something
else. Okay. So there's a mass, there's a soft tissue mass in the in the suprarenal region. It looks quite separate from the kidney. There isn't a definite claw sign. With the bone abnormalities, my number one differential at this stage is metastatic neuroblastoma.
Right. So here you are. So this is a classical 2B film. In the exam, what will happen is that each film carries equal marks. So if you are examined on a plain film, that is, a separate examination or a separate film. And this ultrasound will have similar marks. First of all, give me a quick answer. Normal, abnormal?
Abnormal.
Okay, so can you describe it? I want to hear a particular word here in your description, I mean to say.
This is a pelvic radiograph of a child patient with an immature skeleton. There's a diffuse skeletal abnormality affecting the entire pelvis and more prominently the right proximal femur, with patchy areas of increased and decreased bone density.
To sum up this appearance, is a word there in your vocabulary? Hint, it is in your Chapman.
I mean, if it was a skull, I might call it salt and pepper.
Okay.
But it's not.
Okay. Okay. So, are you worried about an aggressive process, or what is happening?
I think in places I am, because there's areas where I can't define the cortex.
Right.
For example, if you look at the right inferior pubic ramus, and so this could be a disseminated malignancy, in which case I could call this bone moth-eaten.
Moth, say again?
Moth-eaten?
Exactly. This is exactly what I was trying, for description, this is what it is. It is what we call moth-eaten bone. And the differential remains the same. You see the top two? Neuroblastoma, Mets, leukemia, they go together. So this is a moth-eaten bone. Okay, well done. Candidate 2, please get ready. After 2 films, I'll ask you to raise your hands. Now, this I showed you before also when we were doing Paget's disease, and people have done this mistake in the exam, and that is why I'm showing you. This is diffuse Paget's disease, and this is a moth-eaten bone in a child. And there have been candidates in the past who have called this, they just jump to this appearance and this is moth-eaten, without realizing that look at the age group. This is different age group. Then you look at the post trabeculae, you look at the expansion of bone, and then you, oh, this is Paget's. This is classical Paget's. So beware of this pitfall. Another case of moth-eaten, and you can see even the epiphysis this time, here and here are partially involved. So same multiple cases of similar pathology. Now, I did not find a good case of skull. Skull film is extremely important pediatric film for the exam. So remember it. So I'm showing you all of this so that you can understand what will come in the exam. They will show you a skull X-ray in which there will be, let's say, the sutures, they might be widened and there might be some destruction. And the differential is mets from neuroblastoma and leukemia. So these pictures tell you what happens. These are take neuroblastoma from 3 different examples. So this is the type of case which you are expecting in the exam. But you can see that it can go into the bone and it can cause this periosteal reaction. Here from the dura, it has gone into the bone. So skull X-ray in pediatric age group with differential of both of them is very important. I remember, 30 years ago, they used to say that mets from neuroblastoma, it causes widening of the sutures of the skull, and leukemia does not. But later literature corrected it, and they said no, there is nothing like that. Both of them can cause widened sutures. This case is just for differential diagnosis, and candidate 1, differential diagnosis of what?
Well, there's a multiple sclerotic bone lesions.
Excellent. So give me the top causes of sclerosis of the bone in an adult.
So sclerotic metastases. So in a male of this age, prostate would be my first differential. Other causes could be hematological, such as myeloproliferative disorders, myelofibrosis, and so on.
Okay. So myelofibrosis or myelosclerosis or myeloid metaplasia is, we'll come back to the differential diagnosis. I think I have not put the slide here. We'll see it, because the idea was to sort of revise the differential diagnosis. This is for rapid reporting, normal or abnormal. I'm giving you 30 seconds.
I think it's abnormal. I think there's a sclerotic lesion of the left ilium.
Okay, so there is a lytic lesion. Can you pick up a lytic lesion, and it is in the either of the 2 iliums?
Okay. Well, I mean, there is bowel gas overlying, which makes it a bit more tricky.
So let me tell you that it is a definite finding. Look at the right side.
Yeah, I mean, there's a sort of circular lucent area just over mid crest. Yeah.
Okay, now, I this projects much better for me on my laptop than it is projecting on Zoom. So I can understand it might not be projecting very well for all of you. Having said that, this is a classical exam case. And here, you see on this, we can see a lucency here, which is a definite finding. Compare it with this, and this is different. So these kinds of cases, rapid reporting stuff actually. But by the way, sometimes they have been asked in the exam also, as in the viva. So examiner can ask you anything. So this is just for completion. Uh, Lymphomas can be sclerotic. Please remember that lymphomas can be lytic, lymphomas can be sclerotic, and basically this is for differential diagnosis of a sclerotic vertebral body, and this one was lymphoma. Lymphomas can be in the long bone. You know, the picture will be totally non-specific. You cannot diagnose it, but of course you can pick up that this is an aggressive lesion. The idea is to keep lymphoma in your mind. You know, when we do the bone tumor chapters, which we have already done, uh, we don't talk about lymphoma there, right? And in a child, we don't talk about eosinophilic granuloma, what we call LCH, Langerhans cell histiocytosis. Today, my emphasis is that on that differential diagnosis, you have to pick up, include other things also in the exam. Lymphoma is one of them, aggressive lesion. Leukemia is another one, which we have just covered. In a child age group, neuroblastoma is another one. In a child age group, LCH will be one, and then brown tumor of hyperparathyroidism is extremely important. And similarly, hemophilia is very important. Pseudo tumor of hemophilia. So all of these we are going to sort of see today. Now, this is the diagram which I told you last time that it is my favorite diagram. I've taught for years and years on this, and we have taken it out from the latest Chapman because there were many mistakes. But having said that, I just want you to concentrate here on the diaphysis, Ewing sarcoma, lymphoma of the bone. So I've just shown you a case there. And these things are important for your differential. If the examiner asks, you should know that within the diaphysis, what kind of lesion I will consider aggressive lesions. Myeloma, central chondrosarcoma. So this is another case of lymphoma, but this time it is in the epiphysis and metaphysis. Yes, please. Is the bone density increased or not?
Yeah, I think there's a general increased bone sclerosis.
Okay, with it's a giveaway. With urticaria, what comes to your mind?
Mastocytosis.
Mastocytosis. On the CT, what are your findings?
So the findings are the same of generally diffusely increased bone density throughout the visualized skeleton.
Mm-hmm. And what's happening to the viscera?
There's an ascites.
Mm-hmm.
Just wonder. I think overall the hepatic density looks quite normal.
Mm-hmm. Is it a bulky looking spleen?
Yeah, it could be a slightly large, and you can see on the coronals the spleen.
What are these structures here? Of course, on a single cut, it's very difficult.
So I suppose they could be kind of foci of extramedullary hematopoiesis, or
something more simple, which you report every day. Hint.
Nodes.
Nodes. Here you are. Now, mastocytosis is a very important exam case, particularly for differential diagnosis. In mastocytosis, irony is that years ago, people did not consider it a neoplasia. Now we consider it a neoplasia. Basically, there is proliferation of mast cells. Where is this proliferation? This is in the reticuloendothelial system. And reticuloendothelial system, bone, spleen, liver, lymph nodes. So there can be sclerosis of the bone, there can be hepatosplenomegaly, there can be lymphadenopathy. These are young patients usually. So, and the sclerosis of the bone can be diffuse, as in this case, or it can be patchy. So it will come in the differential diagnosis of generalized increased bone density, and it will also come in the differential diagnosis of multiple sclerotic lesions. These are slightly different. different, and they are given in your Chapman. So, and you can be seen, shown something, which I'll cover in GIT once again. So this is a case of mastocytosis, not generalized increased bone density, but you can see that patchy sclerotic lesions, slightly different. Another case, and this is a sort of an ivory vertebra type of finding. I already showed you a lymphoma there. So mastocytosis is important for differential diagnosis. Okay, classical exam. This is your last film, and then number 2, candidate number 2. Classical exam film. Over to you.
So this is a frontal pelvic radiograph of a 42-year-old female patient. The striking abnormality is centered around the right superior pubic ramus, which is expanded. There's cortical thinning, and I can't well see the pelvic side of the bone cortex of the superior aspect. So it's possible that there is some focal destruction there. The overall appearances are lucent, with a few coarsened septations or trabeculae within it. I am concerned that this could be an aggressive lesion. Although early lytic stage Paget's is within my differential, I can't prove that this isn't an expansile lucent metastasis, so I would probably want to do an MRI.
Okay, this is classical, what we call soap bubble lesion. It is lytic with multiple locules, multiple septations, axial bone is involved. And one concept you have to remember, that when we teach bone tumors in long bones, we give a lot of weightage to these words, narrow zone of transition versus a wide zone of transition. This concept doesn't hold true in the axial skeleton. So in axial skeleton, there, many of the aggressive lesions might not have a classical, what we call a wide zone of transition. So take home point is that.
So is this a plasmacytoma?
Okay, here you are. It is. It is. And so my question will be that what is your differential? And I am asking you on the basis of the radiological appearance, the soap bubble appearance.
Well, aneurysmal bone cysts can have a septated or soap bubble type of appearance, and can occur in the pelvis.
Aneurysmal bone cyst, 42-year-old. You see, aneurysmal bone cyst is a different age group, right? And it should not be, these soap bubble appearance. Soap bubble is classical for?
Well, another aggressive lesion which could happen in an older patient would be a telangiectatic osteosarcoma.
Okay, that's very aggressive. This appearance is classical for metastasis, and metastasis from renal cell carcinoma and thyroid specifically.
Right, yes, yeah, lytic metastasis.
Right, you remember that. You knew that, isn't it?
Yes.
Well done. Yeah. So, so this is a classical exam question, and you have to remember that. Okay, thank you very much. Well done, very well done. And candidate 2, please raise your hand.
Hey, hi.
Okay, so candidate 2, can you hear me, please?
Yeah, I can hear you. Can you hear me? Hello?
Okay, yes. Okay, so I'm going to tackle this case. This case is again a lytic lesion, and this one is in the sacrum. Though the resolution of this film, this is a scanned image, so it is poor, but just to develop your eyes, that the lytic lesion is in the sacrum. And in the exam, what happens is that people confuse it with bowel gas and they might miss it. Usually it's difficult, but when it's, this finding is emphatic, it is definite finding. So this was in the sacrum. So these ones are easy. Okay, a few cases for rapid reporting. And of course, right now, because you know that we are doing what we call multiple myeloma or plasmacytomas, etc. But in rapid reporting, they can come and very usually, right? So here, candidate 2, what is the finding? Normal, abnormal?
Abnormal. There's multiple lucencies in the diaphysis of the right humerus and
Okay.
medullary veins.
Okay, that's fine. Lytic lesion, multiple lytic lesion. Please remember the rule of rapid reporting. Rapid reporting rule is that the film will have a single pathology or it can have same pathology at multiple sites. So they can show it to you. And once you pick up one, you don't worry about there are 2 or 3 or 4. Just go to the next case. Don't worry about it. So these kinds of films can come, some of these for rapid reporting, and this is from a skeletal, survey where you have got this, you have got this, etc. Okay, this is a Viva film, and this is for observation. Now, observation film yesterday or day before yesterday, when we covered the previous session, I showed you in the end many observation films. Observation films at times are what I call warm-up films also, where examiner might show you a film which has got a subtle finding. Once the finding is picked up, the film might come down. And the important thing which the examiners are seeing there is your observation. And as I told you last time also, that these films, the technique is that you will not pick up the subtle findings immediately. So don't panic and start describing, go through your protocol and you will pick it up. The key thing is don't be quiet. So candidate 2, over to you.
So there's an abnormal lucency over the left pelvis. It's
When you use the word pelvis, can you be more elaborative?
So it's in the left ilium, projected cranial to the left acetabulum. It's
excellent.
lucent with
Please
margins.
Stop there. So this is the finding. This is the finding, and it's a definite finding, right and left. Okay, similarly, there is a abnormality, and because of time factor, I am going to help you. It is on the right side, though the film quality is poor, but the abnormality is well seen. Where is it?
In the pubic minimi?
Okay, no, so not here, but I don't blame you because the resolution is poor. But let me give you a hint that the finding is definitely present. And let me give you a hint. Compare right and left femora.
So there's an area of abnormal medullary lucency in the proximal femur.
Name the area of femur.
So I think it's in the proximal diaphysis.
Okay, you're talking about this. This is projectional. Anything in the neck of femur?
Yeah, if you compare the lateral right neck of femur, there's a sort of increased haziness. The cortex doesn't appear to be as well defined.
Okay, so the point is that if you go back here, look at this neck of femur, look at the trabeculae, and these are normal. Look here, trabeculae, and then you pick up a lucency. So these trabeculae are gone here. So the quality of film is poor, but having said that, there is a definite finding there. And this is a definite finding. So this is another observational film. Pelvis is just like hands. You know, two of the most popular in the exam. Of course, chest is one of them. Chest, hands, and pelvis. These, for observational films, these are the most critical. And the key is in pelvis and in hands, if both hands are there, compare, particularly in pelvis, compare right and left. Compare right and left. And when you are describing it in the exam, give yourself time and keep talking like this. Tell the examiner, I am comparing right and left. I'm looking at the head of femur. I'm looking at the neck. I'm looking at the metaphysis, diaphysis. Go in details, particularly if you have not picked up the finding. And do not panic. So that's the key. Keep talking, keep talking, keep talking. That's the principle. Any findings?
So there's a lucency over the frontal bone.
So if okay, this is projectional, but having said that, I wanted to show you this thing, you know, these punched out lesions. Of course, I don't blame you because of the resolution of the film. Okay, you are going through this scan in the exam and you have reached the top of the brain. You have not picked up anything within the brain. These are the top images which you have seen. What will you do next?
So I would change it to bone windows.
Excellent. So here you are. This is the bone window. And what is your diagnosis?
So there's a lucent lesion in the right frontal skull, which is well defined with increased density centrally. There's an overlying soft tissue mass which extends outwards. I can't see any evidence of intracranial extension. There are also multiple lucencies throughout the skull vault bilaterally. And I'll be concerned about myeloma or plasmacytoma in this patient.
Okay, so in this case, we can see multiple lucent bone lesions. One of them is definitely aggressive with a soft tissue component. So this was a case of myeloma, multiple myeloma. The key point is that when you are looking at these kinds of scans, go for the bone window and only then you will pick it up. This case I have shown you before also, but I just wanted to repeat today for those of you who have missed it. Very important concept. And because you might have seen it before, we know that this vertebra has got a fracture, and I am not worried about this fracture. Having said that, do you think that the bone marrow is normal or abnormal?
Abnormal.
And why do you say abnormal?
On the T1 sequences, the bone marrow is of lower signal compared to the intervertebral discs.
And on the stir sequence? This is the stir.
It appears to be abnormally high on stir.
Okay, that's fine. I'll take over. So this concept is a very important concept and very important for the exam. Marrow, MR signal in the marrow is a huge subject, and we are not perfect there. So nobody is asking you things in which they will ask you black and white things in the FRCR level. So the black and white concept is that on a T1 weighted, now these are normal. This is a T1, this is a T2, and this is a stir sequence. And stir sequence, which is STIR stir, short tau inversion recovery. This is a physics term, of course. By definition, it is a fat saturated sequence. So it nullifies the fat, and anything which has got water will be high signal. So you can see the CSF is very bright. But now on a T1 weighted sequence, the king sequence for marrow is T1. On a T1 weighted sequence, if you go back to the basics, please remember that we have got fatty marrow and red marrow. In a child, red marrow will be more. But as we grow, fatty marrow, increases in magnitude. So because of that, overall, on a T1 weighted sequence, the marrow is high in signal intensity and higher than the intervertebral disc. That's the rule. Or if it is another part of the body higher than the adjacent muscle. I'll show you a case. And that has also come in the exam. So these 2 points are extremely important to remember. Whenever you find abnormal signal on T1, lower than the intervertebral disc or lower than the muscle, then you look at the stir sequence. This is a normal stir. So you have to develop your eyes. And you can see that it is low in signal. But if there is something abnormal, it will be low on T1 and it will be high on the stir sequence. If you see here, look at this vertebra. Initially, you don't pick up the finding, but if you look carefully, this signal is less than the adjacent disc or this disc. And then you look at the stir, and this is high in signal. Compare it with this norm. So this patient has got diffuse multiple myeloma, and everything is abnormal. It is a totally abnormal skeleton. This finding can also be seen in metastasis. So this is a case of CA lung, where low signal, everything is low, and high signal on the stir. So this is another example. Same patient, which I have shown you in the previous one, has got what we call a super scan. As I always tell you that I don't know much about nuclear scan, but one of my colleagues two of my colleagues are going to go through with the nuclear scan for the exam. And super scan is one of the scan which comes in the scan, and you should know the differential diagnosis of this. Look at this example. And here, this is a young patient, so marrow has got more red component. But if you look carefully, look at this vertebra, and it is more, the signal is lesser than the disc. Look at the muscles, and you will agree that this is lower than the muscle also. This is a case of diffuse leukemia, which shows the same principle. So this principle is an exam principle, and remember it. Let's say osteomyelitis or things like that, they will also cause the same finding. Okay, candidate 2, over to you. This is a T2, this is a T1, and this is a stir sequence. Over to you.
So these are selected sagittal images of an MR. The marrow appears to be abnormally low on T1 and stir sequences. There's also the thecal hemangioma. Given in the history that the patient has anemia, and with this abnormally low signal, myelofibrosis will be one of my top differentials.
Okay, very good. Now, here what is happening, that it is very low as compared to the disc, but it is not high on the stir sequence. So this is slightly unusual. So what can happen? And one of the causes is myelosclerosis. The same case, if you see on a plain film, will have generalized increased bone density. Basically, in myelofibrosis, what happens if you go back to the pathology, the medullary cavity is replaced and it is fibrosed, and then there might be some ossification of it. And because of that, increased bone density is present. So where will be the marrow? The marrow is gone. And because the marrow is gone, it will look like cortical bone. So it can be low signal on T1 and low on stir. Please remember that in the real world, because of patchiness of the process, every case might not be like this. That's the pitfall. But having said that, a classical case can be like this. So this is myelofibrosis. This is another patient in which generalized increased bone density is present. This is from literature, and here they make a point that sometimes with contrast also you can make sure to know that there is nothing infiltrating into the marrow. In this case, there is low signal on T1 This is where the veins, they come into the vertebra, so there is a high signal. This is post contrast, and on post contrast there is no enhancement. This is not for your 2B. Nobody is going to ask you this thing on your 2B, but I just wanted to show you for your concept. Because if there was some infiltration inside, as in diffuse metastasis or leukemia or whatever, that would have enhanced. So this is just to make a point. Okay, we stop here. I'll give you a 5-minute break. There is a feedback form here, and if you can, last time also I was a bit disappointed that the number of feedback forms we are getting is not all that much. So I think this is the minimum you can do, because we have got a concept that without feedback form there is no teaching. So whatever we are doing for you, if you can do this bit for us, please give a feedback. And you can give it now, you can give it in the next break, you can give it at the end of session. So I urge you, all of you, to do that. Right now I'm switching off my and I'm muting myself. 5-minute break now.
Langerhans cell histocytosis and an infective process such as osteomyelitis, I would investigate further with an MR.
Excellent, well done. So you remember when we were doing bone tumor chapter, we did not consider eosinophilic Langerhans cell histiocytosis. But if you want to add something, that Langerhans cell histiocytosis, particularly in a child, include it in the differential diagnosis of everything in the bone. May it be in the long bone, it can be in the diaphysis, it can be in the metaphysis, and it can be in the epiphysis also. So it is good that we have not included it in that diagram, but as a matter of principle, you should add it in the differential. Now, another thing about Langerhans cell histiocytosis is that this concept, and this is from your Chapman, the second part, you will find it very useful. Anything which is given there, it's a very good summary. And the new concepts about it, Langerhans cell histiocytosis. We used to use the word Hand-Schüller-Christian disease, or the word book memory. So the pages from your man. We divide it into this uniform unisystem. So basically, there's a lesion, and it is only in bone, and most of these are 70%. And multifocal unisystem disease, 20% of cases. And then comes this one, which is very aggressive, multi-system disease, which is 10% of cases. So if you see the age group, this unifocal unisystem disease peak is 5 to 15 years. This one, 1 to 5 years. And this one, less than 2 years. Poor prognosis. And then there are subtypes, high risk, CNS, low risk. You have to understand the CNS. CNS is very important for your exam. I'll show you when we cover CNS, the stigmata of LCH in CNS. But you can read from here, but the take-home point is very simple. These are multiple lesions, and they can be anywhere. They can be lytic. They are lytic. They can be aggressive. They can cause periosteal reaction, bony destruction, and they heal, by the way. So most of them, the prognosis is good, and the patient comes out of it. So floating teeth is one of the exam films, which we will cover in the head and neck. Important exam film. In what we call in adults also, there is a type which can happen. So Now, this particular case, just to make a point that on a bone scan, there is another lesion here, and candidate 2, what are you going to do when you see this bone scan?
So I would correlate with any previous radiograph of.
Okay, so you have to ask for a radiograph. On the radiograph, there is a lytic lesion. Basically, this is a case of, one system but multiple lesions. Now, a bit of how do the lesion look like in the skull? One of the things is on this diagram, it is said that it gives you a beveled type of the edge of the lesion because the outer table is involved to a lesser degree as compared to the inner table. So this is known as bevel. And just to, this is what it is, right? And this is a tangential view which projects it like this. It is described in literature. To pick it up like this at times becomes hard, but you have to understand this. Literature also tells us that it is not pathognomic for LCH, this finding. Having said that, in the exam, they might have got a classical case, so this thing should be in your mind. This is another example. Okay, candidate 2. Can you describe this lesion for me in the skull?
Yeah, so there's a lucent lesion in the posterior skull with a very faint area of density centrally, and the margins of the lesion appears to be sclerotic. And
what do you think about the edge? You see from here to here.
It has a slightly sclerotic, there's some irregularity to the edge bilaterally. So there is some sclerosis, but it's not circumferential areas of lucency and sclerosis.
My point is different. My point was that this is though end on, but this is the classical bevel. If you see here, this is one edge and this is second edge. Because you are seeing end on, actually this is what it is. Are you with me? So I want you to develop your eyes on this finding, and the examiner will love that because you have picked up this thing. How have you described this?
So I thought there was a central area of increased density, so I was wondering if this is a Butter sequestrum.
Excellent. So what is your conclusion?
So eosinophilic granuloma.
What is your differential diagnosis for this lesion of button sequestrum?
I think you can get it in osteomyelitis and possibly lymphoma.
Lymphoma, no. Osteomyelitis, yes. So button sequestrum is a very important exam case. This is a good example where you can see the beveled edges. You can, if you stretch your imagination, the inner table is the outer table is this one. This is the inner table. So you can see that they have been involved slightly differently. But button sequestrum comes in the exam, and the differential is, as you have told us, it is LCH versus chronic osteomyelitis. And the concept behind it, the theory, should I say, behind it is that they say that in the central part, there is a bone fragment which, because of avascular necrosis, it remains high density. Just to show you a, quite aggressive case of multifocal LCH, so many lesions. Again, so many lesions. I want you to, how will you call this? I just want you to, there is a collapsed vertebra here. Candidate 2?
Yeah, is it vertebra plana?
Excellent. Vertebra plana means that there is collapse, right? and you can see there is a collapse here, collapse here. These cases have come in the exam again and again. Key thing there is that you have to see the intervertebral disc. That is the key next to it, because in the exam you will be worried, is there infection or not? So the key thing is look at the intervertebral disc. If the intervertebral disc is normal, don't go into the infection world. What is the differential diagnosis of collapsed vertebra in a child? It is in front of your eyes. Eosinophilic granuloma or LCH, Ewing sarcoma, mets from neuroblastoma, osteoblastoma, and TB. So this is the differential. And the point is that intervertebral disc will really help you. This is from the literature. Look at this one on MR. This is the type of case you should be very careful in the exam. So this is a vertebra plana. Look at the intervertebral disc, look at the intervertebral disc, and don't go into the world of infection. And in this case, even the, this soft tissue is slightly abnormal. Go back to this picture and it tells you the vertebra can go here and here. And it also tells you that it heals. So this has healed. So that is important concept. Another case which you have already done, which is aggressive. Now, this is the take-home point, and just this picture should be in your mind for your exam. LCH can happen in epiphysis. It can happen in metaphysis. It can happen in diaphysis. It can be aggressive looking. It can be in the the short bones of the hand, etc. Possible anywhere. It can be in the axial skeleton. It can be in the skull. So remember it everywhere, right? Yes, please. Do you think anything comes to your mind, the shape of this femora?
So,
femur rather.
in the morphology that we discussed, the metaphysis appears to be expanded.
So what do you call this appearance?
And in the mask deformity.
Right. So, and with that background, what's happening?
So there's expansion of the medullary cavity in the right hip. They have a cannulated screw. The left femur also appears to be slightly abnormal. Is this LCH in an adult patient?
This is what is happening here. Sclerosis. Hint: we have crossed now LCH. We have gone beyond that.
Right. So it's bilateral avascular necrosis. Could it be something like sickle cell disease?
So Gaucher's. This is 40-year-old, and just to give you an example, I don't think so anybody is going to show it to you, but Erlenmeyer-Flass deformity it can cause avascular necrosis. This was the old concept of treatments where they used to put it, and the concept was that the pressure will be released and there will not be any development. I just wanted to show you just for completion because it is in the differential diagnosis. This is Niemann-Pick disease and Gaucher's disease. Okay, last thing in the chapter. Over to you.
So in the right femur, the intercondylar notch appears to be expanded. There's also abnormal calcification and degenerative change on both sides of the knee joint, the distal femur.
Just to make a point that maybe it is projecting for you as calcification. Actually, this is not calcification. Please continue. It is just soft
Okay.
tissue.
So there's significant soft tissue, degeneration of the joints, widening of the intercondylar notch, and I'm giving the information that it's a male patient. So the most likely diagnosis would be hemophilia of the knee,
Right.
with I'll correlate with the patient's blood markers to see if they do have hemophilia. If they don't have hemophilia, then JIA would be a less likely differential.
Okay, that's fine. So in hemophilia, please remember the concept that there can be hemorrhage. Where can this hemorrhage be? And that will make the radiology. The hemorrhage can be recurrent hemorrhages, can be within the joint cavity. It will, so when the hemorrhage is in the joint cavity, what is happening? That there is hyperemia. And because of hyperemia, there is accelerated growth. There is accelerated growth and of the epiphysis, and there can be premature closure of the epiphysis. So that can happen, and the patient might present in this age group with deformities, but epiphysis will be, and we have seen the same cases with JIA, and in JIA, similar pathology happens, but similar effect happens, which is hyperemia, but because of some other concept. Now, second thing is that I told you that there can be what we call bleeding within the joint, and then there can be bleeding within the bone. So there can be lucent lesions within the bone, particularly subchondral bone. And then there can be bleeding in the periosteum. When it happens in the periosteum, it causes bizarre appearances. We call it pseudotumors. Pseudotumors are very important for the exam because they will be, if you don't know it, you are never going to pick it up. And pseudotumors are extremely important. Now, in this particular case, what is happening, if you see carefully, there is widened intercondylar notch. And we have done the differential diagnosis for this widened intercondylar notch. JIA also is there. If you see this epiphysis, it is larger as compared to this. These changes are secondary changes. But look at the soft tissue, and the soft tissue is quite dense. They say that this is the only way to discriminate on a plain film between hemophilia versus JIA. On hemophilia, the soft tissue will be more dense. I think it's a sort of a subjective phenomena. And these days, of course, we do MR, and that resolves the matter. Can you describe this one for me?
So in this L radiograph, the radial head appears to be expanded diffusely, and there's also a loose lesion in the proximal ulna. This may represent bleeding with subcondylar bleeding with early closure of the radial head epiphysis, given this pathognomonic appearance for hemophilia.
Right. So two joints which are most important for hemophilia, one is knee and one is elbow. And, they are affected much more common. And here what is happening, that the head of the radius, it is larger. Same phenomena which has happened. So this is the concept of this, inside, and this is periosteal bleeding within the bone bleeding, which can make your radiology. This is just to make a point that, when you do MRI, you will see hemosiderin, and it is similar to, we have seen cases of PVNS previously. Hemosiderin will be low signal on T2 weighted sequence. So in hemophilia, chronic bleeding, you can pick that up. This is another case, and you can see a cystic lesion here. You can see that the head of the radius is slightly enlarged. Yes, please.
The subluxation and dislocation of the right joint. There's also a large expanded right ilium with a central lucency. It's fairly well defined. It appears to only be affecting the right hemipelvis. Differentials for this appearance, it may represent an aggressive lesion of the right hemipelvis, such as an Ewing sarcoma, although the patient's slightly older. Given that they're a male patient, it may represent a pseudo tumor of the right hemipelvis if the patient's hemophilic.
Right. So fine, because in the exam you are never sure what's happening. But having said that, this gives you that bizarre appearance, because in the concept is that there is subperiosteal bleeding, and which really destroys the bone. You can see that there is dislocation of the hip, and if you see a CT scan, you know what is the appearance. So this is another case from literature, which gives you a lytic type of lesion with some internal septations also, and you can see how it looks like. So hemophilic pseudotumor should be in your mind. Just like a brown tumor of hyperparathyroidism should be in your mind in the differential diagnosis. So this is the same thing, but this one is in the calcanea. Over to you.
So the left femur has a very bizarre appearance with multiple diaphyseal lucencies on both sides of the lateral and medial aspect. There's also expansion of the periosteum proximally, and I wonder if this represents subperiosteal hemorrhage with cystic pseudotumors given this appearance.
Yeah, that's fine. So, you know, absolutely bizarre. You cannot, it doesn't make sense, isn't it? You know, something is sitting here, and then something is sitting here, something is sitting here, and this is a bizarre appearance, and you know, it doesn't fit into anything. And so this is another example of hemophilic pseudotumors. Okay, now we go to the next chapter, and candidate 3, are you with us? If you can raise your hand. Candidate 2, thank you. Can you hear me? Candidate 3?
Yep.
Okay, welcome, and just wait for me, please. Candidate 3, can you see my screen and can you hear me?
Yep.
So this is your case. This is going to be an interesting chapter. Many films will go quickly, and many of the things in this chapter are for differential diagnosis also. And I will particularly concentrate on hyperparathyroidism, and I might show you 20 different films in hyperparathyroidism. Very important for the exam, and so many films come in the exam, and so many presentations are there. So for hyperparathyroidism, please concentrate on that aspect particularly. Over to you, please.
Okay, so this is a radiograph of the hand for a child. There is an abnormality in both wrists with slight widening of the distal growth plates of both the radius and ulnar, with some fraying of the metaphyses. There's also some periosteal reaction at the radial aspect of the ulnar diaphysis.
No, don't worry about this.
Okay.
Yeah. Just concentrate on the what we call the metaphysis.
Okay, so there's a generalized sort of lucency of the distal metaphyses and a cupping.
Very good.
On the distal ulnar metaphyses, there's sort of bony spurs at the edges. And this can be seen to a lesser extent of the distal radial metaphyses. I think the most unifying diagnosis of these findings would be in keeping with rickets.
Rickets. Okay, well done. Now, if all of you concentrate, because I have seen that people do confuse rickets with scurvy in the exams. And the main thing is that if we go back to the basics, this is from your Chapman, and I recommend that you read it from here. Basically, what is happening. Now, if you go back to the metabolism of the bone, because we are in the metabolism of the bone, this is the chapter, metabolic and endocrines. Bone has got two components. One component is the collagen, and the second part is the mineral. So collagen is protein. We call it the osteoid, and the mineral is calcium. So if the collagen part or the osteoid part is deficient, we will call it osteoporosis. Scurvy, for example, basically it causes osteoporosis. And on the other hand, if calcium is less, so that's the second type of disorders. So rickets is one of those examples. If the skeleton is not grown, we call it rickets. Otherwise, we call it osteomalacia. So in rickets, what is going to happen? Now, this is the epiphysis. This is the metaphysis. So let me show it here. This is epiphysis. This is metaphysis. This is the growth plate. So the growth plate is where the growth happens. And at this end, there is zone of provisional calcification where the calcium it deposits. Because calcium is not enough, then what happens is that there is what we call fraying. These words should be in your vocabulary. So you should be describing it like that in the exam. Widened growth plates, this distance has increased. Then there is fraying, splaying, and cupping of the metaphysis. So these words have to be in your vocabulary. Then what happens? There is a tiny bony spur extending from the metaphysis to surround the uncalcified growth plate. So this spur, C, this C is very important for you to understand, because I have seen again and again and again over the years. In your exam, you are going to confuse this spur with what we call Falcon spur in scurvy. People pick this up and they say, oh, this is scurvy, and they make up the rest of the findings. So this point is very important. And of course, then this cortex can be indistinct. And sometimes, in some cases, there can be what we call pseudo-periosteal reaction. In pseudo-periosteal reaction, what happens is normal wear and tear of the bone is that it's a growing skeleton. Under the periosteum, new bone is deposited. This is normal metabolism, and a normal osteoid is deposited there. But this osteoid is deficient of calcium, so the density is lesser than the periosteum, and it gives you an appearance of a pseudo-periosteal reaction. Any examiner who has got that film will show you, and every case of rickets is not like that. So this, I warn you, this thing should be in your mind, and you are going to confuse it with scurvy. So don't jump to this conclusion, that this is Pelkan spur of scurvy. So I'll come back to this when we will consider scurvy. So now this was our case, and you can see the same finding, fissuring, etc., widened. This is the spur, this is the spur, and there is cupping and fraying and splaying. All of these words we can use here. Look at this one, and again there is fraying and splaying, widened growth plate, metaphyseal spur here. So please remember that age-wise, as the baby grows, it can happen then in the knees also. It can happen in the ankle. Any other bone can be involved. Now, this particular case, if you see, to discriminate, this is the spur, the confusing spur which I was talking about. This is, look at the epiphysis, and this epiphysis is not hypodense. In Wimberger sign of scurvy, this will be hypodense, and there will be a sclerotic rim. So we will see it shortly. Okay, candidate 3, over to you. We know, I can tell you that this patient has got rickets. You tell me the findings. This is a very, very, very good 2B film. It has come in the exam.
So this is a frontal and lateral chest radiograph for a 3-year-old patient. There is a diffuse abnormality in the shape of the vertebral bodies in the thoracic spine.
Don't worry, that is just projectional, I'm not worried about this.
Okay.
Please look at the ribs.
Okay, so focusing on the right side to start with, the ends of the anterior ends of the ribs are quite frayed or sort of
Excellent,
cut,
well done.
with some quite wide or large costochondral junctions.
Very good. In keeping with?
In keeping with rickets.
What is the differential for this particular finding? And that has also come in the exam. Let me give you a hint.
Mm-hmm.
So basically, let me elaborate once again. What you have picked up, that look at these ribs. This is the costochondral junction. So the cartilage is here, and there is widening or splaying of the costochondral junction. This lateral film, as an examiner, I can just show you this lateral film, and you have to pick it up. Look at this, look at this, look at this, right? Now, costochondral junction is widened. And if you go back to your Chapman, again talking about book memories, look at this, rickets. Increased non-calcified osteoid in immature skeleton, mainly a disorder of growth plate and equivalents. For example, costochondral junction. And this word will save you a film in the exam. So the point is that whenever there is widened costochondral junction, think rickets, fine. Second thing, over to candidate 3 once again. Any other differential comes for this finding?
Can you include scurvy with the sort of cupping?
Okay, let me give you a hint. What can happen in the metaphysis of long bones? Something which can happen in the metaphysis of long bones with periosteal reaction. If you find a X-ray with bilateral metaphyseal periosteal reaction in a long bone, let's say humeri, both humeri, what will be your differential?
Would you consider something like NAI?
Excellent, definitely. So the point is that in NAI also the same finding can be seen. So consider it equivalent to the metaphysis, simple as that. So in NAI also you look for this finding. Okay, well done. So here is a case actually, and this is NAI. Can you pick up the findings, please?
So this is a frontal chest radiograph for a 5-month-old infant. There is an abnormality in the anterior right ribs where there is widening of the anterior portion with possibly some widening of that costochondral junction,
Excellent.
possibly some callus formation.
Excellent. Anything happening here in this region where I'm pointing out?
I think there are similar findings on the left, although more towards the lateral aspect. There looks like there's callus formation around the lateral aspects of the ribs.
Excellent. So if you see the oblique film, that is confirmed. And the point to remember is that costochondral junction widening is synonym of having a periosteal fracture, a metaphyseal fracture in a long bone. And this kind of finding, as in a fracture of the rib, should not happen in a baby, because in babies the ribs are quite flexible. So this is a slam dunk case of NAI. But just on this basis also, you can suggest. So healing rickets is given in your book in Chapman as in the differential diagnosis of solitary radiolucent metaphyseal band, and this is that metaphyseal band we are and then it has healed. So just to make a point that it is in healing rickets, solitary radiolucent metaphyseal band. The growth plate basically is widened because it is not calcified, and when it calcifies, it becomes less prominent. I've shown you this case before in the first chapter. This case is a case of rickets. The findings are a bit subtle, but you can see a bit of fraying, etc. What's happening in the diaphysis, candidate 3?
There's bowing of the diaphyses.
And with that?
And looks like some, on the right, there's quite marked periosteal reaction, solid periosteal reaction.
Right, and in the left also. You see this thing? This line. Are you with me?
Yeah.
And similarly here. So this is a case of rickets, but this rickets is causing that pseudo periosteal reaction. This is bilateral symmetrical periosteal reaction. Bowing also, if you go back to your book, which divides, changes at the growth plate, changes due to bone softening, and bowing of long bones is given there. So bowing is there, and with that, this pseudo periosteal reaction is. So that is why it comes in the differential diagnosis of periosteal reaction bilateral symmetrical in children. Okay. Spot diagnosis. This is it will be difficult for you to pick up as a spot diagnosis because this is another example of an observational film for the Viva. Once you pick up the finding, the film will come down. Over to you.
Okay, so this
Or
is
you can concentrate on this one.
This is a frontal.
Let me tell you, I'm not interested in the lung. I am not interested in the heart. I'm interested in the bone. Over to you.
Okay. So frontal chest radiograph for a 32-year-old male. Focusing on the bony thorax, the left humeral head is not clearly seen.
I'm not interested. Don't worry.
Okay. Okay, looking at the ribs, I can't see any focal.
Look at the scapulae, please.
The scapulae.
Yeah, right and left. Both of them.
Okay, so on both sides there is a horizontal lucency at the lateral aspect of the
Here is it.
scapular bodies. Yeah.
What is your conclusion?
I think these are looser zones.
Excellent. So, yeah, that's fine. So these are classical loser zones and a classical exam case. Loser zones, the concept of loser zones is it's rare to see loser zones in rickets, as in children. It can be seen, but rare. Usually it is seen in adults, and they will show you films of adults in the exam. Classical observational film, your eyes see what the mind knows. Now, please remember that there are some sites on which loser zones are more commonly seen. Axial skeleton is up there. In chest X-ray, ribs, remember, and it has come in the exam quite a few times. Loser zone of the rib, scapula. I'm showing you. They can happen in the pelvis, in the femora, etc. There are multiple sites. The basic concept is that the theory behind it is that again there are micro infarctions, normal wear and tear, which fills up with osteoid, normal osteoid, but it is devoid of calcium. That's why it appears like this. So this was a classical case. In this case, candidate 3, look at the femora. Anything abnormal?
So at the medial aspect of both femoral necks, there's a focal lucency with surrounding increased sclerosis. Okay,
excellent. So if you see here, look at this and look at this. So another example of loser zone, again exam case. Loser zone, as this is actually the same patient. And if you can see here, look at the fibula and you can see loser zone here, loser zone here. What does it tell you? It is not dependent on weight bearing, etc. And that is why it occurs more commonly in axial skeleton. So loser zone is a very important observational film. This patient has got a loser zone in one of the ribs. Though the film quality is not good, but it is visible. Over to you, candidate 3. Where is the loser zone?
So it looks like it's in the posterior left.
Left?
Yeah, I thought it was in the...
Okay, look at the right side, please.
Okay.
the hint is that though the film is poor quality, but the finding is visible.
Oh, is it the lateral 10th rib?
Okay. So if you see here,
Yeah.
look at this, 1 and 2, and this one is definitely visible. This is a bit doubtful. And if you see a close up, this one is definitely visible. These are kinds of films which will come in the exam for observation. Once you pick it up, the film will come down. You know, there might not be much of a viva there. There might be a theoretical question: what can be the causes of osteomalacia? And then they will go to the next question. Okay, over to you.
Okay, so this is a frontal and lateral projection of the knees and tibia and fibula for a 3-year-old male. Bilaterally, the epiphyses, proximal and distal epiphyses of the tibia and distal femur are lucent with a well-defined sclerotic rim. The metaphyses are dense with some underlying lucent bands. The distal metaphyses are also slightly widened, and the fibular metaphyses in particular appear cupped.
Okay, so don't worry about anything else. Just give me your diagnosis on the basis of this.
Okay, I think that particularly the epiphyseal appearances are quite convincing for scurvy.
Scurvy. Okay. Okay. So here you are. The difference between rickets and scurvy. Remember that this is osteoporosis. So what is going to happen? One of the key points for the exam is it doesn't happen before six months of age, and this is very important for you to remember for differential diagnosis. And because there are enough stores from the maternal blood. Now, if you see here, this is the epiphysis. The epiphysis will be low density because of osteopenia, and the margin will be sclerotic, and this sign is known as Wimberger sign. So develop your eyes on Wimberger sign. Then is what we call the Frenkel line, dense zone of provisional calcification in the metaphysis. So this metaphysis is not classically cupped like rickets. This is cupping, right? And it is not cupped and it is dense. And the point of confusion is this. What is this? This is known as Pelkan spur, and it represents healing metaphyseal corner fracture caused by bone weakening, resulting in metaphyseal cupping. Now, this is why many students confuse scurvy with rickets because of this cupping. And the concept is different. Once you pick it up, don't jump to conclusion. Look at it. There is no cupping of this portion of the metaphysis. Look at the Wimberger sign, and don't jump to this conclusion. Then whenever I see cupping, I will call it rickets, or vice versa. This thing here, Trummerfeld zone, is lucency under Frenkel line. Means that this is the Frenkel line and there will be a lucency. By the way, this is a projection of their soft tissue. Not a very good sign. This, Trummerfield zone, you will not see in each and every case. Then there can be subperiosteal hemorrhage. And when this happens here, then there will be what we call, whenever there is hemorrhage, it will cause periosteal reaction. And this is why it is considered in bilateral symmetrical periosteal reaction in a child. So you can see 4th September and 18th September, and there is periosteal reaction like this. Oh, sorry, I was going back actually. Spot diagnosis, what's happening here?
Is that fractures through the metaphyses?
What is your diagnosis?
So those would be Pelton spurs of scurvy.
Why do you say that? You see, look at this. This is normal, isn't it?
Oh, they're normal, yeah.
Yeah.
Well, then I'd consider NAI quite high up on my differential.
This is NAI, right?
Yeah.
Okay, this one is just for your differential, because this differential should be in your mind. It's a difficult one and it's not pathognomic. This is just for discussion's sake. And you can see this is periosteal reaction here. The bone density can be increased. There is periosteal reaction here. And this is hypervitaminosis A, usually occurs after the age of 1 year. Remember that. And I will show you a differential in your Chapman toxicity, and we will come back. Remember the type of toxicities which can happen in a child versus the type of toxicity which can happen in an adult. And there's a difference, which I will elaborate further. But you have to remember vitamin A because of that. It can cause increased bone density. It can cause a bit of periosteal reaction. Age group is more than 1 year. Here you are. Generalized increased bone density. Poisoning. Just concentrate here. What kind of poisoning? Lead. Very important exam case. Fluorosis, very important. Hypervitaminosis D and chronic hypervitaminosis A. To discriminate it with adults, please remember fluorosis can occur in adult as well as in child. Lead will not occur in adults. Hypervitaminosis A will not occur in adults. Interestingly, hypervitaminosis D can occur in adults, but the radiology will be different. It will not cause increased bone density, but it can cause a lot of soft tissue calcification, which is again an exam case. So this portion you have to concentrate now. Here you are. I have shown you this case, I believe, previously also. Soft tissue calcification bilateral. There is here and here. And of course, the differential diagnosis will be, let's say, things like renal osteodystrophy because of hyperparathyroidism. And this concept, if you can concentrate, we have covered it previously. So I'm quickly just revising it. Soft tissue calcification. There is a concept of what we call dystrophic calcification. Sorry for the typo here. And metastatic calcification. We have covered it before, but metastatic calcification, dystrophic means that the calcium metabolism is normal. Here, metastatic means that the calcium metabolism is abnormal. There might be hypercalcemia of any cause. And the most important causes are hyperparathyroidism, particularly secondary hyperparathyroidism, or vitamin D toxicity for your exam. So this word metastatic means, what does it mean and what kind of films can come in the exam? We have already covered tumoral calcinosis, which is a specific condition which occurs in Afro-Caribbeans. And it's a bit of a familial thing. And there is a lot of calcification anterior on external surface, extensor compartments of large joints. Okay, what do you call this? Sign.
It resembles the letter H.
Okay, so what is your conclusion?
It's suspicious for an insufficiency fracture.
Excellent. So insufficiency fracture by definition is fracture of normal, abnormal bone with normal stresses, as in osteoporosis. And stress fracture is abnormal stresses on normal bone. So one of the classical signs in the spine is that within the sacrum, you will see this H-shaped fractures. And this is a stir sequence where you can see it. In the exam, they have shown nuclear scan for the same thing, which is a H vertebra. We call it the Honda sign. Not H-shaped vertebra, but Honda sign. And okay, this case has got, just concentrate candidate 3 on these fractures. Or I'm just looking for a description here. Over to you. How will you describe this?
So there's loss of height anteriorly in the L1, 2, and 3 vertebral bodies with sclerosis of the superior and inferior end plates. The generalized bone appears quite osteopenic. I think these findings would be in keeping with moderate to severe grade anterior wedge compression fractures, secondary to probable underlying osteopenia.
Okay. Do you see, if you see this superior end plate, do you agree that, this whitish callus formation here is a bit more than what you usually expect?
Yep.
And how do you explain that? What comes to your mind? What pathology comes to your mind? And I warn you, this has come in the exam. Okay, let me ask the question in a different way. When you see exuberant callus formation post-fracture, a classical exam film will be where they will show you a chest X-ray with multiple fractures in the rib, and it's an elderly patient, and lot of exuberant callus formation. Or they will show you a spine film where there will be, this increased band of density in the collapsed portion. The pathology for which it is known to happen is, anything comes to your mind?
Hyperparathyroidism.
No. Hyperparathyroidism, this is Cushing's syndrome, right? In Cushing's syndrome, basically what is Cushing? Cushing syndrome and Cushing disease, you should remember that disease means that there is hyperfunction of the pituitary. So there can be long cases here where they might show you this X-ray with let's say a pituitary microadenoma, and you should correlate that this is Cushing disease. And Cushing syndrome means increased steroids for any other cause. For example, iatrogenic, or they might show you a long case where there will be a bronchogenic carcinoma which is producing steroids, and with that this finding. So you should understand that in Cushing syndrome or Cushing disease, what's happening is that there is osteoporosis. Because of osteoporosis, there are fractures. One of the pathognomic finding in Cushing's is that there is exuberant callus formation in the vertebral body. They are representative of high density at the collapsed portion. And another thing is ribs, which they can show you. So these are biconvex ribs with that. And I'm just showing you a few examples for long cases also, and story type of cases where they might show you avascular necrosis with stigmata of previous surgery, means this patient had a surgery of the adrenal. At this time, it must be Cushing syndrome, etc. So you have to keep your minds open for that. Now, we come to the last part of MSK, and the last part is endocrines. So this is the first film of endocrines. Over to you.
Okay, so this is a chest, sorry, not a chest radiograph. This is a frontal radiograph of both hands. There is a diffuse spade-like appearance of the distal tufts of all fingers with some associated soft tissue swelling or thickening. There's also diffuse interphalangeal joint degenerative changes.
What's happening here?
There's sort of overhanging edges or spurs forming at the radial aspect of the metacarpal heads.
So what is your conclusion?
So in conclusion, I think these symmetrical findings are in keeping with acromegaly.
Excellent. The only thing is this word was not coming to your mind. We call them metacarpal head hooks. Hooks is the way to describe it, right? So these are spade-like arrowhead. So this is acromegaly. Acromegaly, what happens is that you can get a skull X-ray also. And on a skull X-ray, please remember, you can get a X-ray where there will be what we call widening of the pituitary fossa. But please remember that most of these patients are because of microadenoma, not macroadenoma. So you might not get this finding. Just to make a point that this is a case of a macroadenoma, and you can see that actually it has gone into the sphenoid sinus. We will cover this in CNS. We'll revisit this. But coming back to that, these what we call the paranasal sinuses are very prominent. And look at the mandible, hyperkinetic type of mandible. So these are the classical findings of acromegaly. Now, in acromegaly, another thing is that it is in the differential diagnosis of posterior scalloping. Now, posterior scalloping in the first chapter, when we did, you remember there were things like tumors in the spinal canal, neurofibromatosis, etc., achondroplasia, and then acromegaly is also there. If you look carefully, look at this vertebra. What is happening is that there is posterior scalloping. Another finding, which is pathognomic for acromegaly, if you see here, this is the original vertebra, and anterior to that is new bone formation. This is also seen in acromegaly. These are subtle findings. I don't think so these are important for the exam, but at least you should remember posterior scalloping as a differential diagnosis, and you should know, because posterior scalloping per se is a very important exam case, and you should know this, that acromegaly is one of the differential. Here you are, posterior scalloping of vertebral body, acromegaly. Yes, please. 5-year-old male.
Okay, so these are bilateral hand radiographs and a pelvic radiograph for a 5-year-old male. The most notable abnormality is that there is a general absence of the epiphyses in all radiographs.
Excellent. Conclusion.
This, in a patient of this age and with these findings, this would be in keeping with congenital hypothyroidism.
Right, very good. Basically, what's happening is that there is decreased bone age. So if you see here, you don't have to have an atlas of developmental anatomy to highlight to see that these epiphyses, many of them should have been visible in a 5-year-old. This also tells you, right now you are seeing a slide there on which 5-year male is written. In the exam, what will happen? The examiner is going to open this case and initially will tell you this is a 5-year-old male. And suppose you have not understood that this is a 5-year-old male. So your mind will not go into this finding. So please remember that whatever the examiner tell you, the history or anything might have a meaning. So be very attentive to that. So as soon as you understand that this is 5-year-old, you say, oh, something is wrong. These epiphyses should have been visible. So hypothyroidism or congenital or cretinism, whatever, basically what happens is that there is delayed ossification. You can get delayed ossification. You remember that it was in the differential diagnosis of irregular or stippled epiphysis, congenital hypothyroidism. And that is why it is very important for the differential diagnosis. And you can see that stippled epiphysis can also occur. The sutures, they might be widened, etc. These findings are visible. And another finding is bullet-shaped vertebra, anterior tongues. You remember in the first chapter, we considered things like achondroplasia and mucopolysaccharidosis, where there are anterior tongues. Again, very important exam case. And hypothyroidism is one of the differential. And this is healed in this example, 1952 and 1956. So in 4 years, now the baby is fine. So this is your last case, and candidate 1 should get ready. So candidate, yeah, please continue. Sorry.
A radiograph of both hands. There is bilateral, reasonably symmetrical periosteal reaction at the radial aspect of the index and middle finger proximal phalanges. There's also some lucent lesions in the distal phalanx of both thumbs, with some secondary degenerative changes.
So you have picked up bilateral periosteal reaction. This is, of course, an adult patient. So it will come in the differential diagnosis of bilateral symmetrical periosteal reaction in adult. What comes to your mind?
In an adult, in the hands, I believe these findings are seen in thyroid-related disease.
Okay, and that's fine. So the differential diagnosis is here. Thyroid acropathy or acropathy, whatever, is one of the causes, which is what it was. But please remember that we have covered this HOA previously, and you know that in HOA, small bones can again be involved, and in pachydermoperiostosis particularly. And this age group will be younger. This is familiar. Now, this is in here. What happens is that these patients might have had a surgery or thyroid ablation, and even then they present with this periosteal reaction. They might present with what we call thyroid eye disease or thyroid associated orbitopathy, where the muscles, etc., are thickened. We'll cover this in head and neck. So all said and done, this thing should also be in your mind vis-a-vis a long case. So it might come as a long case component of some other stigmata. I think we have got half an hour to go. I'll give you a 3-minute break here, just a 3-minute break. And in half an hour, then we should be able to finish it. After the break, it will be candidate 1. So I'm switching off for the next 3 minutes. Okay, so this is going to be a rapid fire type of a section. My main aim is to show you, you can tackle this as a Viva film, and then we will go in a rapid fire mode.
These are frontal radiographs of both hands of an adult patient. There's no fracture or dislocation. I can see some poor definition of the cortical border of the proximal phalanges, specifically the right index and second and probably third also on the radial aspect, consistent with subperiosteal bone resorption. And having seen that, I think probably the trabecular pattern is a bit fuzzy. So I think the appearances are consistent with hyperparathyroidism. Okay, very good. Now, I am going to show you maybe 20 odd films of hyperparathyroidism, and I'm showing it to you intentionally. Very important case. So many unusual presentations, many subtle findings, and you will not see, most of you will not see it in your real life. So that is why I'm showing you. Now here, what is happening is that there is subperiosteal bone resorption on the radial side. Here, if you look carefully where I'm pointing out, you can see a bit of acroosteolysis here also. Now, basic concept is that in hyperparathyroidism, there can be bone resorption. Where is the bone resorption? Now, this concept, if you remember, you can make the radiology. It can be subperiosteal. So when there is subperiosteal, the outline of the periosteum will be fuzzy. It can be, on the other hand, intracortical. So it is in the cortex. This time you might see a lucency here in the cortex, but the periosteum will be crisp and sharp. So this differentiation is an exam differentiation, and this, you have to develop your eyes on this versus this. There can be end osteal, on the the inner side. There can be trabecular resorption, and add to this these words: subchondral, subligamentous, subtendinous. So there is resorption, and so that is one component of the radiology of hyperparathyroidism. Now, if you see here, fuzzy outline. So this is subperiosteal resorption. Look here, and distally, there is a bit of acroosteolysis here, and then another example. Now, this is a very good example of subchondral resorption. Subchondral, under the cartilage, and you will confuse it with erosion, as in erosive arthropathy. If you see here, this was the cartilage, and there is resorption here. There is a cartilage here, and subchondral resorption is there. So if in the exam, if you pick up as an erosion, I will not be surprised, but once you know it and there are some other stigmata on the film, then you can make sense. So I warn you about subchondral resorption, particularly in the hands. Candidate 1, this is a known case of hyperparathyroidism. Describe your findings. Again, frontal radiographs both hands.
Yeah, excuse me. Just concentrate on this hand because of the time factor.
So there is subperiosteal bone resorption of the ulnar aspect of the index proximal phalanx. On the radial aspect, there is an appearance that looks like a periosteal reaction, but in this context might represent intracortical bone resorption with tunneling.
Excellent.
And then there's
anything in the metacarpal, please.
So again, there's similar features of lucency within the cortex of the bone.
Mm-hmm.
It's on both sides. It's symmetrical.
Okay, I'll take over. Well done. Now, if you see here, you can see that subperiosteal resorption, but here, crisp and sharp outline of the, so this is intracortical. Here also, here is subperiosteal. Look at these signs. Distal tuft resorption. Here, definitely intracortical. Look at this one, intracortical. So similar findings are visible here on this side. Okay. This is hyperparathyroidism. Give me the finding.
So this is a frontal chest radiograph of an adult patient. There is a bit of lucency and poor definition of the distal third of the clavicles, more obviously the right.
Okay, stop. So what is happening? Look at the clavicles. Both of them are resolved. And remember the differential diagnosis of erosion or absence of the outer end of clavicle. And hyperparathyroidism is one of the differential. So, again, your eye, your mind will know what the eye sees. So you have to concentrate on these kinds of findings. This finding, there is nothing else on this film. So, but point I'm teaching here is that it is given in your books in the differential diagnosis of sacroiliitis, hyperparathyroidism is given. And I covered it before. So I told you that in your book, it is given as bilateral symmetrical. Actually, it's a pseudo finding because there is, by definition, subarticular bone resorption, which gives you this radiological finding. You remember case of rickets where there is a pseudo periosteal reaction. It's a radiological finding. So here there is no sacroiliitis, but because of subchondral resorption of bone, you get this finding. And sacroiliitis and hyperparathyroidism, your book tells you it's a mimic. So this was hyperparathyroidism. Okay, spot diagnosis. This is hyperparathyroidism. What appearance comes to your mind?
As a lateral skull radiograph showing small lucencies throughout the skull, which you could be described as salt and pepper pot skull type of appearance.
Pepper pot.
Or
okay.
Salt and pepper, maybe.
Okay. So the pepper pot is find multiple small holes, and salt and pepper will be a bit of sclerosis with holes. So these pictures should be in your mind. And this is a salt and pepper, more emphatic type of a case. So once you know it, you will not be confused. So spot diagnosis, considering that we are in hyperparathyroidism.
So in that context, the well-defined lytic lesions within both tibias are brown tumors.
Right. Now, if you have a discussion on this case, and if I grill you in a viva mode on this film, just try to see that, there are lytic lesions, expansile with narrow zone of transition, benign looking, one here, one in the fibula, and start going into details and start thinking, what can it be in a 27-year-old? And nothing will come to your mind, These are nothing else in the world. 3 different locations. So this is brown tumor, and nothing else comes into the differential. So think brown tumor, always it should be in your mind whenever you see some unusual lytic lesion. Classical exam case. What are your findings?
So these are AP and lateral radiographs of an elbow. Sorry, the resolution just dropped quite suddenly for me.
Resolution is dropped?
Yeah, so there's a calcified, dilated tubular structure over the antecubital fossa. The location and shape of this is that of a sort of fistula. That's normally associated.
Very good. What's happening in the elbow?
So, for example, at the olecranon, at the proximal aspect, there's a fuzzy border that looks like bone resorption. So I think this is probably end-stage renal failure, renal osteodystrophy, and secondary hyperparathyroidism.
Okay, excellent. So basically, this is a vessel, so means that there was a fistula which is calcified, and this is an example of subtendinous, subligamentous bone resorption. There must be some olecranon bursitis also. You can see bone resorption here, osteopenia here. So all of these go with hyperparathyroidism. Now here, what do you think about the bone density?
It's generally increased.
Okay. Do you pick up any soft tissue calcification?
There are calcifications sort of adjacent to the thumb metacarpals, but they look like they could be vascular.
Vascular. And what's happening here? For example, just concentrate on this one.
So there's notable fragmentation and bone resorption in the distal tufts.
What I am trying to ask you, just concentrate on this one. This is the distal end of the phalanx, and this is not exactly the distal end. Does it make sense? There is resorption of bone here.
I mean, if there's trauma, it could be a fracture, but it's
no
present
trauma.
in lots of them.
There is no trauma.
So maybe that actually represents a sort of looser zone type of thing.
3 types of acro-osteolysis can be seen in hyperpara or secondary hyperpara. The resorption of tuft, resorption of mid portion, and periarticular resorption. This is the answer. So you have to develop your eyes on this. Resorption of tuft is very common. Periarticular, you remember I showed you a case and I described it in detail. This is the mid portion, and people get confused. If you know it, then you don't get confused. So please remember the definition of secondary hyperparathyroidism. Primary hyperparathyroidism is usually because of an adenoma. There can be other causes also, but secondary hyperpara in the developed world, first world countries, usually it is secondary to renal failure. And in the developing world, it is rickets and osteomalacia can cause renal osteodystrophy, secondary hyperpara. In secondary hyperparathyroidism, soft tissue calcification is much more significantly seen. You remember that metastatic calcification. So it can be in the vessels, it can be it can be in the muscles also, and so all of this can be explained. Now, just remember the definition, the radiological findings for the exam for renal osteodystrophy. So these are changes. Renal osteodystrophy are changes of hyperparathyroidism plus changes of rickets / osteomalacia according to the age of your patient, plus increased bone density. So 1 + 1 + 1 makes renal osteodystrophy. I repeat, changes of hyperparathyroidism plus changes of rickets or osteomalacia and increased bone density. Why is there increased bone density? There are theories. We are not going to go into it. Nobody knows actually. So these are the causes of secondary hyperpara. Of course, renal osteodystrophy can be another cause, which is also a type of a secondary hyperparathyroidism. Generalized increased bone density in adults, and the causes given, one of them is renal osteodystrophy, and generalized increased bone density in a child, renal osteodystrophy can be there. Please remember that. Distal phalangeal destruction we have already covered. You see this thing, resorption of mid portion. This is what I showed you right now. So in the exam, if you have seen it, you will pick it up. So because of time factor, I'll just ask you leading questions. What do you think about the bone density?
So out with the lytic lesions, the actual density elsewhere is increased.
What is your conclusion?
So probably there is renal osteodystrophy because there's both brown tumors and increased sclerosis.
Yeah, and if I had time and I could go into details of this, grill you in a viva mode, what can it be? And nothing else can explain this. Increased bone density with this type of narrow zone of transition type of lytic lesions. So brown tumors can have various kinds of appearances, and here again, brown tumor which has got a narrow zone of transition. Please remember what happens when the hyperparathyroidism, clinically speaking, is in control. The lesions might persist, the lesions might heal, and this is an example where they have healed and there is a bit of sclerosis inside. Okay, this is a classical exam film, absolutely classical. So I will like you to take it. All of you, please concentrate because this is a very good to be film. Over to you.
So this is a frontal radiograph of the pelvis and proximal femora of an adult patient. There's a right femoral hemiarthroplasty in situ. I noticed some surgical clips over the left hemipelvis and amorphous area of calcification projected over the right hemipelvis that looks to be within the soft tissues. The bones in general look osteopenic, and there are patchy areas of increased and decreased bone density in the femoral.
Okay, what is happening in the diaphysis here and here?
So it looks like there are small sclerotic areas projected in the medullary cavities.
Look at the periosteum.
Oh, and then there's on both sides symmetrically there's a periosteal reaction with new bone formation.
Is it new bone formation?
Or it's cortical tunneling.
Here you are, and this thing here is a brown tumor actually, and this is this is loosened now because of this. This is means this patient had transplant, and now this is a dead kidney, and this is that. Again, similar findings to what you saw in hand, hyperparathyroidism. This case is a very, very good case. It's not projecting very, it is from one of the scanned films in our collection. So this patient had a fetus inside, but this patient has got the classical findings of renal osteodystrophy. Absolutely classical. So though the quality is poor, but if you see, look at the SI joint. So this is that pseudo sacroiliitis. And then look at this loser zone. And then there is bone resorption. This is here. You can see in the inferior ramus, if it was projecting well for you, you would have seen that there is subperiosteal resorption here, and there is generalized increased bone density. So this is a classical case of where there is loser zones, as in osteomalacia. There are findings of hyperparathyroidism, and there is generalized increased bone density. Roger-Jersey spine can be seen in renal osteodystrophy. And just quickly, we have already covered it, that metastatic calcification like this, metastatic means that this patient has got hypercalcemia, can be because of renal osteodystrophy. It can also be because of hypervitaminosis A. Hypervitaminosis D. So renal osteodystrophy. another case where there is resorption of the clavicle. Classical, exam type of case where you can see a transplanted kidney lying here, and you can see this subarticular bone resorption of SI joint. And another one where you can see subarticular bone resorption, you can see soft tissue calcification, you can see a brown tube. Again, because of hyperpara, there is soft tissue calcification, vascular calcification around the digit, everything has to go. Okay, we are just in the last 4 or 5 cases left, and we have finished hyperpara. So I have intentionally shown you many cases there, and I hope you get a film in the exam and you get it right. So, candidate 2, are you with us or you are left? If you have, okay, so I can see a hand there. Okay, these are, I think, last 4 or 5 cases quickly. This case, let me tackle it. Candidate 2, are you with us?
Yes, I am.
So this case is, I don't think so anybody is going to show it to you in the exam. Now we are going into the world of hypoparathyroidism. And this patient has got basal ganglia calcification. In one era, this was an exam case, no more. Because now on CT, you see calcification in basal ganglia region in 50% of cases. It is usually idiopathic. It's not pathognomic for anything, and nobody does a skull radiograph, so it's not expected in the exam. But just to make a point that in hypoparathyroidism, basal ganglia calcification can be seen. Now, yes, please.
So the 4th and 5th metacarpals bilaterally appear to be shortened compared to the other metacarpals.
What is your differential diagnosis for this?
Pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, and Turner's.
Excellent. And interestingly, it's the concept of pseudo-hypothyroidism and pseudo-hypoparathyroidism is that in pseudo-hypoparathyroidism, actually, it's a familial condition, and organ resistance is there, and with that you get these small metacarpal. Pseudo-hypoparathyroidism, they say, actually is a more of a bony thing. It should not be called pseudo, but somehow the other we are lingering on with this word, where there is only a skeletal finding, but the biochemistry is normal. So there is nothing to do with hypoparathyroidism. It's just a skeletal abnormality. This is pseudo. Nobody can say that this is pseudo, but for differential diagnosis, the examiner can ask you. Yes, please.
Okay, so this is a radiograph of both knees in a skeletally immature patient. There is bilateral dense metaphyseal bands in the distal femur and proximal tibia bilaterally. It's also affecting the proximal fibula metaphysis. Differentials for this include lead poisoning and I think iron poisoning.
Which poisoning?
Lead and iron. Hello?
Iron, no. Rather, they become sclerotic, and usually they will show you X-ray of the knee like this. please remember that you have to develop your eyes on this finding, because metaphysis can normally appear a bit sclerotic. They say that the metaphysis of the fibula should not be sclerotic normally, but these ones are slightly, this case, this is a absolutely pathognomic case, but I'm talking about subtle cases. But fibula, if you see fibula, you call it. Now, basically what happens in lead poisoning is, now look at this case and you will agree that this is a bit more subtle, and but even here the fibula is involved. This X-ray of the abdomen gives you a story. Candidate 2. What is the story? It's fine.
So they've ingested something. There's multiple foci of radiodense material scattered throughout the abdomen.
They have ingested? Very good answer. But what have they ingested?
So it must be something that contains lead, I suppose, when you put it with the appearance of the knees.
So can you make a story out of it? Now it is a story case for CR.
Things that contain lead.
No, why has it gone into the abdomen? Let me take over. Now, what happens is, why lead poisoning? So please remember that lead poisoning previously and maybe it might be happening even now in some of the developing world, but previously what was happening, that the paint which was produced, the paint which we use in our homes, that had lead. So what happens is that when there is humidity, etc., there are flakes which fall down from the ceilings of rooms, or when there is leaky roofs, etc. And these flakes are lying on the floor. And babies who are crawling babies, let's say 1 year old, they are crawling and they put those flakes in their mouth and they just swallow it. So this is the story here. This is one of the mechanism of lead poisoning. Lead pipe was another one, and burning of lead batteries is another one, where lead batteries are burned for fun and at times for just to pass time. And you can inhale the fume, and the children can get lead poisoning from there. I think this is actually the last case of the day. Good. Over to you.
So this is a patient, 47-year-old male patient with diffuse increased bone sclerosis in the chest and in the hands bilaterally. There's also calcification of the intraosseous membrane between the radius and ulna. The sclerosis appears quite diffuse, and the top of my differentials for metabolic cause would be fluorosis as a potential cause in an adult patient. Other causes include malignant causes such as mastocytosis, diffuse prostatic mets.
So in mastocytosis, do you expect periosteal reaction or this?
No. I think it's unlikely. I think fluorosis would be...
Would you like to take that back, mastocytosis?
Yeah, I think it's unlikely given the calcification in the intraosseous membrane with the periosteal reaction. So I'll probably just keep fluorosis.
Here you are. You see, if you have a debate on this case, and so we are into two different differential diagnoses in the same case. Generalized increased bone density with this, you can call it pseudo-periosteal reaction or periosteal reaction, whatever you want to call it. In fluorosis, other than fluorosis, nothing fits in both of these categories. So a unifying diagnosis has to be fluorosis and nothing else. Now, in fluorosis, what happens is that there is periosteal reaction, and most commonly of the interosseous membrane between the radius and ulna, and sometimes tibia and fibula also. So we call it periosteal reaction, and that is a pathognomic finding. At times, it can be seen around other bones also. So this is quite pathognomic. So the last take-home point from this case is, by the way, this is the rest of the X-rays of the same patient, where you can see generalized increased bone density in the spine as well as the pelvis. This is fluorosis. So last point, exam point to remember, again, I have described it before, but I want to emphasize it again. In your mind, you have to make compartments to be able to remember things. And one of the compartments should be poisoning. And in poisoning, what are the take-home points? The take-home points is that, remember, in adults, remember fluorosis. Fluorosis can cause periosteal reaction in adults, and it can cause, what I just described in the previous case, and it can cause increased bone density. Another poisoning in the adults is hypervitaminosis D. Interestingly, this only causes soft tissue calcification as far as radiology is concerned. But in children, there are 4 types of poisoning: lead, fluorosis, hypervitaminosis D, and hypervitaminosis A. So fluorosis is the only thing which is, radiologically speaking, common to both of them, and it can cause similar types of findings. Please remember that fluorosis is quite common even in this era. And during even the last few years, there have been various reports of fluorosis, various parts of the world, whole village with fluorosis, that kind of a thing. Now, lead poisoning cannot happen in adults. Hypervitaminosis A cannot happen in adults. Hypervitaminosis A, remember, will cause increased bone density and can cause periosteal reaction. I showed you a case, and I told you that it usually post 1 year of age. Hypervitaminosis D in children can cause soft tissue calcification and can cause increased bone density also. So in this compartment of your mind, you differentiate between the poisoning in adults and children and the radiological features, and this will be very helpful to remember the differential diagnosis. So with that, we come to the end of today. And one announcement to make is that, of course, after I switch off in another 1 minute, I urge you to, give feedbacks. The more we have got, the better it is for us. And anything you want to add in future or whatever, you can give in your feedbacks also. Now, another point is that next session we are starting GIT, and on this will be Thursday, my usual session 6 to 9 British time, British summer time, and on that day I will give you the program for the next session, and I might announce interventional radiology session also in the coming week. We have to increase our pace because a lot to cover, but hopefully utilizing weekdays as well as weekends, we will be there. So, okay, thank you very much and have a good night.